Hello, my name is Kay Walters. I'm a registered respiratory therapist and the respiratory care director here at Jackson. What I'd like to go over in this session this morning is three things: oxygen safety, oxygen delivery devices, and how we work together as a team, a little bit about the respiratory therapy department here. So we're going to start with oxygen delivery. First of all, every patient bay in this hospital should have an oxygen flow meter, and frequently you will see an air flow meter. The oxygen flow meter is green. The air flow meter is yellow. You always want to train your eye to look for the green on the oxygen flow meter before you set up your oxygen. You wouldn't believe how easy it is to make a mistake and just grab that air flow meter. So on the oxygen flow meter you have a Christmas tree. Some people call it a nipple adapter. It should always be clear. If you see one that's yellow or green, throw them in the trash. They turn out to be a safety hazard because they would get crossed and you'd wind up with a green adapter on the airflow meter, and we would find patients on 4 liters of air. So make sure you have the clear Christmas trees. These do come from your respiratory therapist. They're not stocked on the floor by Central, so if you need some extras, let your therapist know. But be aware that if you're in a code situation and you do not have one, the connective tubing of your ambu bag will fit directly onto that flow meter without the nipple adapter. As far as oxygen delivery devices here at Jackson, we only have 2. So you as the caregiver will have access to 2 oxygen delivery devices for your patient. If you think they need oxygen, you're going to let your therapist know, but you're going to be the ones that set it up, in a hurry. So first of all, you have your nasal cannula, simple nasal cannula. It runs from 1 to 6 liters, never more than 6, because you can actually damage the nasal mucosa by increasing that greater than 6 liters a minute, because the lumen of this tubing, the diameter is so small that it creates quite a turbulent airflow or gas flow, and it will damage the nasal mucosa. If you have a patient on 4 liters of nasal cannula or above, let your therapist know, and we will bring you a humidifier. We don't routinely humidify nasal cannulas any longer less than 4 liters because it entrains enough room air to humidify it. However, you may have that patient who has HOMO2 at 1 liter that wants a water bottle, or you as the caregiver or the family complains that the patient's nose is dry. We'll be happy to bring them a humidifier bottle. Your next oxygen delivery device is called an Oxy Mask, and I'm going to go over that in depth, but first I want to explain why we went to 1 mask. I'm sure you're familiar with the simple mask. We don't use that anymore. It ran from 5 to 10 liters. If you turn this simple mask less than 5 liters, patient actually rebreathes their CO2, and it's a safety hazard, so we got rid of that. The Venti mask is a great tool. It has the venturi where you dial in your oxygen level from 24 to 50%, and it's still a great tool. However, the patient's holding their hand over that venturi device and obstructing the venturi, it can change the actual FiO2, or if it's covered up, so we stopped using that one. Non-rebreather. Everybody comes into the emergency room on a non-rebreather via ambulance, right? We quit using this because if you turn it down too low, the patient can also rebreathe their CO2. You will see it ordered 100% non-rebreather. Well, it's really not 100%. 100% oxygen is in this bag. That's the only place in this mask that there is 100% oxygen. Once it is inhaled past this device and also mixed with air through the holes here, it's about 65 to 85%, and the literature supports that. Also, if used incorrectly, again, like the simple mask, the patient can rebreathe their CO2. Now think about your patient who comes in on a nasal cannula and they start to get sicker and you put them on a simple mask. Well, that doesn't work. Their stats are still bad. Let me try that Venti mask so I'll know exactly the percentage of oxygen they have. Well, that's not working, so let me put them on 100% non-rebreather, and that didn't work either. So as that patient is on these oxygen delivery devices and they get better, then you start going in the other direction. So by the time the patient leaves the hospital, after you've gone back from a non-rebreather to a Venti mask to a simple mask, they've used 6 different masks because you know the one that you needed has already been thrown away. So we went to the Oxy Mask for that reason, to save plastic, because this mask will take care of all your oxygen delivery needs. It is an open concept face mask. It delivers from 24 to 90%, which is actually more than a non-rebreather. It will save you having to go grab different masks every time. It also is a wonderful tool because the patient can talk to you. With the open concept face mask, you don't have the loud noise of the non-rebreather. Patients can talk to their families. Families can hear them. You can rotate this tubing 180 degrees, and actually you could give your patients pills, water through that hole. If they were really talented, they could eat through that hole. And this is great because if you think about that patient on a non-rebreather who desats every time you lift up the non-rebreather, now you don't have to, because you can just rotate that out of the way. You can talk to them, you could do oral care, you could give them a pill. We had some skepticism about whether or not an open concept face mask could actually work better than a non-rebreather. And the reason it can, and there'll be one of these available in the classroom for you to pass around and look at, the reason it can is because of the vortex nozzle, if you will, inside this mask. It actually sprays a plume of gas of the oxygen right over the patient's nose and mouth where they need it. So they're constantly being fed that oxygen. Again, it is open, it is comfortable. If you need to know what FiO2 your patient is on, remember that with any low flow oxygen device, whether it's a nasal cannula or a mask, the actual FiO2 that patient receives is completely dependent on their rate and depth of respiration. What I mean by that is your elderly, tiny lady who is on 2 liters a minute and she's been sedated and she's barely breathing, you have to go over there and check her. Most of her minute volume is supplied by that 2 liters a minute nasal cannula she's on because she's breathing so shallow and so slow. You take a football player who just broke his leg and he's on a 2 liter nasal cannula and he's in a lot of pain and he's hyperventilating. He's going to entrain so much room air that he will dilute that same 2 liter nasal cannula almost to room air. So your little lady that's barely breathing slowly and shallowly will get a higher FO2 than someone who's hyperventilating. So that is true of any oxygen delivery device that is considered low flow. But to get a good idea of what your FiO2 is, you can look at the tab that is on every single Oxy mask as it comes out of the bag. It will tell you the FiO2 at each liter flow from 1 to 15 liters a minute. And again, you will notice when you look at this and pass it around and check it out, it's a fairly wide range of FiO2. And again, that is because the rate and depth of respiration affects that. When you go to your storeroom to get your Oxy mask, it comes in a package like that. This is actually an extra large size. What you have on the nursing units is a standard mask, a little bit smaller than that. And it fits most patients. But if you have a patient with that extra large facial configuration, let your respiratory therapist know. We will bring you one of these. We also have a small mask, which is actually a PEDS mask, but it will fit your very tiny patients, adult patients. So let your therapist know as well if you need that. Those are the 2 oxygen delivery devices that you have access to as caregivers. Make sure that if you set a patient up on oxygen, you let your therapist know. You're going to enter an order in Paragon for that to notify us that you do have a patient on oxygen so that we can check it and charge for it. The respiratory therapy department is responsible for putting in all the charges for oxygen. Oxygen is a consumable supply charge, so we do have to capture that. The oxygen tank back behind the hospital that supplies the hospital costs the hospital about $7,000 to $8,000 a month. So we do need to recoup those charges and also chart it and make sure that the patient's O2 sats are checked. I know that y'all do that as well. So if your patient is not able to be maintained on that 2 liter nasal cannula or that Oxy mask, the next steps are devices that respiratory therapy handles. We have a disposable high flow nasal cannula that's bright green. It looks similar to your standard nasal cannula, only it's larger. The lumen of the tubing is larger. It will run from 6 to 15 liters a minute. And again, it's bright green to let you know it's not a standard nasal cannula. We don't use those as much anymore now that we have the Oxy Mask. Before, when we used the non-rebreathers, we would use that high-flow nasal cannula on your patient that kept removing that non-rebreather, and they did well on it, but now we don't use it quite as much. We also have what we call an OptiFlow, which is a high-flow nasal cannula that runs from 10 to 60 liters a minute. It runs through a ventilator heater, so that gas is heated and humidified. Has a very large interface, almost like a nasal CPAP device. The indication for that is your patient who is severely hypoxic or has a very high work of breathing. Now, it will not affect ventilation. So if you have a patient with a CO2 problem, the high-flow nasal cannula is not your option. We used to think it was only for severe hypoxemia and used it on patients with PEs and congestive heart failures to try to get them over the hump to avoid intubation. What we learned from years of working with the high-flow nasal cannula OptiFlow is that it will also keep your patients from escalating. Sometimes you'll have that patient whose SATs are good, but their work of breathing is incredibly high, and you can see this. If we can put them on the high-flow nasal cannula, sometimes we can stop them from tiring out and either going on BiPAP or getting intubated. We did a trial in SICU a couple years back, and every patient in the unit that was on 3 liters a minute nasal cannula or above went on the OptiFlow. With the OptiFlow, you can titrate the flow rate independent of the FiO2. So you could have a patient on from 21 to 100% oxygen and from 10 to 60 liters a minute. So what we found is on your patient with 3 or 4 liters, they may only need about 30 or 40% O2, but because their work of breathing was so high, we could even turn them up as high as 60 liters a minute, and it actually helped with work of breathing because with that high of a flow rate, it actually splits the airways open and mimics nasal CPAP. So it treats and prevents atelectasis. So during the month we did this trial in SICU, we eliminated about 70% of our BiPAP usage. So it's a wonderful tool. We tend to think that if a patient fails a normal oxygen delivery device, they immediately need BiPAP, and that is not true. The high-flow nasal cannula is a great tool, a great bridge before you get to BiPAP. Now, when you start looking at non-invasive ventilation and BiPAP, those are your patients who are in impending respiratory failure and have increasing levels of CO2 most of the time. I'm not talking about the individuals who are on nighttime BiPAP for sleep apnea. These are the patients in true impending respiratory failure. We own 8 Philips V60 BiPAP units. We also rent quite a few because the BiPAP population is very high. We use it a lot for impending respiratory failure. So your therapist will put the patient on BiPAP. We do initiate and manage all of the BiPAP therapy. You will even see a lot of patients on that BiPAP or non-invasive ventilation, as it is called, on the general nursing floor. The units are just not big enough to handle that population, and we try to keep them from going on the ventilator by treating them with the non-invasive on the floor. So if you're a nurse and you're taking care of that non-invasive ventilation patient, you realize with non-invasive ventilation BiPAP, you have 2 levels of pressure. You have the expiratory pressure, which keeps the airways splinted open and also helps with oxygen absorption because it's PEEP. But you also have an inspiratory pressure. So when that patient inhales, there's a level of pressure that actually inflates those alveoli. So that patient is being ventilated by that BiPAP machine, and I want you to remember that. If you have a patient on continuous BiPAP, that patient is on a ventilator. Just because there's no endotracheal tube and the patient has a face mask, it is still a ventilator. So if you have that patient that was on that equipment for rescue and they start to get better, say they're a CHF patient and their Lasix kicked in, or they're an impending respiratory failure COPD patient and steroids kicked in, or their other meds, their bronchodilators start to work, well, they feel better. Well, what's the first thing a patient or a family wants for that patient when they start to feel better? They want them to eat. They want them to drink. Please, please use caution before you let a patient on continuous non-invasive ventilation come off to eat or drink. The rule of thumb is they're going to have to be able to stay off that non-invasive ventilator for 2 hours after eating so that their stomach empties. The reason is when you put the BiPAP mask back on that patient and they have a full belly, they will swallow air, they'll get gastric insufflation, and they can have emesis and aspirate. It has happened. As caregivers, we want to do the right thing to make our patient comfortable or our family comfortable, but please use that with caution, because the minute you take that BiPAP mask off that patient on non-invasive ventilation, all those alveoli that are nice and full now start to slam shut. It may not happen immediately. You won't see the results immediately, but they will start to slam shut. And as they do, your patient will get a little more in distress moment by moment, and before 2 hours is up and that food has digested, they're in distress. So please use caution. It may come down to a hard conversation with that physician or with the family or the patient that, I'm sorry you can't eat right now. You are on a ventilator even though there's no tube, and it's just not possible for you to eat right now. Sips of water is okay, but not a lot goes in that stomach if they can't stay off that BiPAP for 2 hours. Please call your therapist if you have a patient on a non-invasive ventilator. Again, we do maintain that piece of equipment. We do every 2 hour to every 4 hour checks to make sure that patient is doing well and no adjustments need to be made. We also check the face mask for the integrity of the skin. As you have that face mask strapped on the patient, you will start to have some redness, or you can. So you want to watch for that as well. BiPAP masks are designed to leak. It may be a little annoying for the patient, the family, or for you because you'll hear that leak. But don't make the mistake of thinking that you need to do something about that leak. Don't go in and tighten those straps, because once the therapist has set that mask in place and adjusted the straps accordingly, the mask is actually designed to float on a cushion of air on that patient's face. If you tighten the straps down, you will cause loss of skin integrity and skin breakdown. We do have some devices that we put in place on a full face mask. It's just a seal that helps to protect the patient's skin. We also have a process in place where we can swap from a full face mask to an under the nose mask to help relieve those pressure points. If you have a patient on a non-invasive ventilator and they have to transport to radiology, or they have to transport to long-term care or to another floor, make sure you call your respiratory therapist, because we have to go on those transports. We actually will transport that patient on the BiPAP equipment. It has an internal battery using oxygen tanks for our gas delivery so that that patient doesn't lose that alveolar recruitment that they have achieved by using that non-invasive ventilator. Now, all that said, we have a huge sleep apnea population, and sometimes they come to the hospital without their own devices. If you find a patient whose family or the patient says, oh, I wear a BiPAP at night, or CPAP, ask them if they have it with them. Ask them if a family member can go get it. First of all, you want to determine that they're actually compliant with that device at home. We've had patients that told us that they used their device and sent somebody to get it, and it comes to us still in the box, never been used. Or it comes to us in terrible condition, full of bugs and mold. So you want to make sure that they're compliant. So ask those questions. If they do use their own machine at home and they use it every night, I promise you they're going to be more comfortable on their home device than they will on our hospital-grade equipment. Hospital-grade equipment is designed to take care of fairly critical patients, so they alarm. Their home CPAP unit does not alarm. So every time they turn over or roll over at night and it alarms, they're going to get very annoyed. So if it's possible for them to bring their CPAP device from home, that would be great. They're going to be happier on that. If not, we will supply one for them. Again, it's a hospital-grade piece of equipment. CPAP and BiPAP are pressures that have to be ordered by a physician. So if the physician writes BiPAP as at home or CPAP as at home, we're going to have to get an order for that level of pressure. Sometimes the patient knows what level of pressure they use. It's really best if the physician writes an order for some baseline settings like CPAP of 10, CPAP of 7, or BiPAP 15/5. We really do have to have an order for that, because if the doctor just writes CPAP as at home, that order to a respiratory therapist is kind of like an order for a nurse that says, just give them some morphine. You wouldn't do that. You would have to have a dosage ordered and a route. So same with BiPAP and CPAP. We need that dosage of pressure ordered. We do have about 24 servo ventilators after we move from BiPAP and that patient needs to go on the vent. We have 2 that are for neonatal use. They live in the nursery. They're universal servo eyes. The rest of the population can serve peds or adults. They also can do invasive or non-invasive, which helps us to take that patient in the ER who may not be ready to be intubated. We can try them on non-invasive on the ventilator, and if they get intubated, we're using the same device. So it's a very versatile ventilator. Respiratory therapy does do all the ventilator initiation and management. Any vent changes are done by respiratory. There is a 100% O2 button that nurses use before they suction if the patient needs to be suctioned. Everything else needs to be a phone call to respiratory therapy. I want to talk a little bit about oxygen safety. These are the tanks that we use here. This is called a walkabout. If you notice, it has a handle that you can move it from point A to point B. It also has a gas gauge here, and much like the gas gauge on your car, you're going to want to check that gas gauge before you take a tank anywhere with a patient. The on-off switch dial is at the top. It goes from 0.25 to 25 liters a minute, and the only attachment you will use is here, where the oxygen tubing goes straight onto the nipple adapter. The other attachments on the side, respiratory therapy uses if we're using this tank on the BiPAP as transport. So that is your oxygen tank. Every nursing unit has a good supply of oxygen tanks. You have lots of carriers like this to transport them in, as well as a multi-cylinder holder, something like this. You may have a cylinder holder that holds 12, you may have a cylinder holder that holds 6 or 4, depending on where you are. Intensive care, endo, ER, those places that use a lot of tanks, they have the larger cylinder holders. The general nursing floors have one that holds about 6. Joint Commission requires that we separate tanks by full, partially full, and empty. Because of space and because of many considerations, we decided to define full tanks as the tanks that live in the tank room on the first floor. Right down the hall from the cafeteria silverware area, as you're going out the back door towards Pine Street, towards the fire department, there is an oxygen storeroom. That is where all the full tanks are delivered, and when tanks are empty, that is where you take them back to. Most of the high-use areas have someone in their area that maintains their tank supply. They have a key to the tank room. When they get too many empties in their empty rack, they take them to the tank room and then get their full tanks and bring them back to the unit. On every single storage device on your unit, it will either say empty or it will say partially full and ready for use. Remember, the only full tanks live in the storeroom. So the tanks that are partially full and ready for use have a blue sign on it that says that. They also have a little spreadsheet that looks something like this. The spreadsheet will tell you how long your tank will last. So if you look at the front of your gauge on this tank, and there'll be one in the classroom for you to look at, there's 2,000 PSI says full, which is a full tank, 2,000 pounds of pressure. And then it goes down in 100 degree increments. When you get to 500, it's red and it says refill. So we made the spreadsheet so you would know how long your tank would last, and it's separated by 2,000 PSI, 1,500, 1,000, and 500. So at 2,000 PSI, which is full, a nasal cannula at 2 liters would last 280 minutes. But a mask running at 15 liters a minute would only last 37 minutes. This is important to know if you have a really sick patient that you're transporting down for a standard chest x-ray. We like to use these tanks as long as is safely possible. What we find that happens is when it gets close to the 500 red zone, people will take the tank and put it in the empty rack. There's still gas in there that we can use, and we encourage you to use them as long as is safely possible. Because if you look over at the 500 chart, 2 liter a minute nasal cannula would last for 70 minutes on that tank at 500. So if you see a tank with 500, that's a good choice to walk a patient around the floor on a 2 liter nasal cannula. They could even go to radiology on a 2 liter nasal cannula. It's a good tool for PT to use when they walk patients. But if you go down the list all the way to 15 liters a minute, a tank with 500 in it would only last 5 minutes, and you would not choose that. So please refer to the spreadsheet on your tank holder that says full or partially full and ready for use, and again it'll be blue. So you can determine how long you can safely use a tank, because we do want to use them and try not to waste a quarter of our oxygen budget. Oxygen safety is a huge, huge issue. The rule is that I want you to remember, if you don't remember anything else I said today, is that every tank has to be stored and transported in an approved carrier. Just keep saying that over and over in your head. Every tank has to be stored and transported in an approved carrier. So when we got these tanks, the Walkabout has this great handle, but what we found was people were carrying them by the handle, and I've even seen some safety videos from other hospitals that says that's okay. It's not. The handle is only for moving it from one carrier to another, like this, because that handle is only screwed on with 4 screws. The screws can come loose, the screws can come on. So if you grab a tank and you do this and walk down the hall with it, it might look cool or feel cool, but it's not, because you could drop it, the handle could come off. If that tank breaks, if you drop it and it breaks at the yoke, it's going through a wall like a torpedo. 2,000 pounds of pressure will cause that tank, the inertia of that tank will take it through a wall. It has happened before, not here that I've ever seen, but I know people who have seen it happen. That is why the rules of oxygen safety are so strict. Every tank must be stored and transported in an approved carrier. So if you walk through your nursing unit and you see that, or you see it laying on the floor like that, or my personal favorite, I have seen this, the tank sitting in a chair. If you see that, it is like a fire. You have got to immediately grab it and put it in an approved carrier. Take it and put it in your dolly or in your storage rack, either partially full or the empty rack. Do a Google search for Mythbusters tanks through a wall, and you'll see what I'm talking about. Their little video was actually an H cylinder, which is the large tanks, but they took a guillotine and broke the yoke of the tank off. Pressure in that tank took it through 2 concrete walls, and it can happen. So if Joint Commission walks into this hospital and they see one tank sitting like that, that's an automatic recommendation for improvement. And we will have to do lots of action plans and lots of education to make sure everybody knows how to store tanks. We did get cited a couple years ago because a very well-meaning person carried it by the handle, set it by the sink, washed their hands, carried it by the handle. And I think they did take it and put it in a dolly, but just that small amount of time to have it unattended is enough for somebody to knock it over and it to go through a wall or through a patient or an employee or a visitor. Very, very serious stuff. So, what does this mean to you as the caregiver? It means that if you have to take a patient on a transport and you need a tank, you're going to have to go to your full, not your empty rack, to your full rack, grab a tank, put it in your dolly, take it to the patient's bedside, take it out of the dolly, put it in the bed holder. Okay? Every bed in this hospital had a little holder at the head of the bed that you can put tanks in. Tanks can't go in the bed with the patient. It has to go in the holder. If you don't have a holder, if it's disappeared, you can always hook this over the head of the bed. Not as safe, but people do it. But look for your bed holders. If you're taking care of a patient and you see that bed holder and you're not using it, don't take it off the bed and stick it in the storeroom somewhere. Please leave it on the bed so that it's there when you need it. So you take that patient from that bed with that tank to wherever they're going, and when they come back, you have left this in the room. You take the tank out of the bed, put it in the holder, and then take it back to your oxygen storage area. This is very serious because of the safety implications. So please help me keep our patients safe by always using good oxygen safety. Now, a little bit about our respiratory therapy department and how we work together as a team. We have about 40 employees, all respiratory therapists, and one office manager who helps take really good care of us. They are at varying levels of education. I have new grads, I have people who have been here for 30 plus years. So we have a great department. We currently have 4 supervisors, 2 at night, 2 in the daytime. The supervisors do take a full workload, so they will be a working supervisor. If you need them, they may have to coordinate their workload with coming to help you. Because of the size of this hospital, if we're running 6 or 7 therapists a shift, therapists have multiple nursing units that they are responsible for. So when you have a need for them, they may be in the middle of something else. So they will probably ask you how bad your patient is, how sick they are, or how quick they have to come. They're not trying to put you off or get out of doing the work. They're triaging the care that they're already giving and trying to determine, do they stop taking care of these 10 patients that they're with on 3 North to go to 3 West. So we depend on the nurses' skills to triage that patient, to assess that patient, to let us know how sick they are. Because it may be that your patient's called for a treatment and they take treatments at home at 8, 12, and 4, and it's 1 minute after 12, and they're mad because the therapist is not there yet, but they're clear as a bell. Or it may be that your patient's in such distress that you're afraid they're going to obstruct. The therapist will ask you what's going on with the patient, how bad are they, and how quickly do I need to get there, so that they can determine if they have to stop doing what they're doing to go see you, and they will if they need to. The respiratory therapists respond to every code 99. They respond to every ICE team call along with the ICU nurses. So if you look and you see multiple therapists running down the hall, we do all respond because we're not ever sure who couldn't respond. It may be that your therapist for your floor, who would be the person to come to your code, is on another floor doing a blood gas, or is on another floor doing a transport with a critical patient on a BiPAP. You just don't know. That's why we all respond. And the supervisor will dismiss the people who are not needed, because you don't want to have too many people in that emergency response. Respiratory therapy does all of the blood gases. We do them point of care with a device called an EPOC. We will come to your unit, do your blood gas. Within several minutes of running it, it's available on a ticker tape printout, which will go on your chart. If there are any critical values on that blood gas, the respiratory therapist has to come find a licensed caregiver, either the doctor or the nurse, and report those critical values to you. If the physician is available on the unit, we will report it to them. But if not, we report it to that patient's nurse or another nurse, and they are responsible for calling the physician that critical value. We also have to ask you your last name, and all of our name badges now just have our first name on them. So we will ask you your last name, because we have to put your first name, last name, and credentials into the blood gas system before we can actually print that blood gas. That way it fulfills all the requirements for laboratory reporting of critical values. And it will live on that printout, and then it goes through the hospital information system to live in the EMR. So they may come and ask you for your whole name when you're giving them the critical values. Respiratory does all of the medication delivery, nebulized medication delivery. We currently do not do meter dose inhalers, haven't in 20 years. The trend is to get rid of meter dose inhalers in the hospital setting because of the cost. There are still some. If you need any help with a meter dose inhaler, something that you're not sure of, let your therapist know. We'll be glad to help you. We will also be glad to bring you an aero chamber, which every meter dose inhaler should be used with. Those can be charged to the patient. It traps the plume of the inhaler in a little spacer, and they get more of the medicine that way. I want to thank you all very much for your time and attention today. Remember your oxygen delivery devices, nasal cannula, and Oxy Mask. Anything beyond that, call your therapist. Also, oxygen, about the oxygen tank and oxygen safety and how we work together as a team. It is our goal to provide to the patients at Jackson Hospital the very best in respiratory care services, and we work very closely with our nursing population to do that. We are a team, and it takes a team effort. Remember that when you need your therapist, we do carry the Cisco wireless phones, almost forgot. And in the morning at 7 a.m. and 7 p.m. you will get a list faxed to your nurse's station that has the name of the therapist on duty, what area they're covering, and their Cisco wireless phone number. Please write that down on your work list. Call them anytime you need something. Anytime there's an order for them, they need that phone call. Because when orders are put into Paragon, they sit on a printer in our office until we come back to the office. And on a busy day, that's only a couple of times a day. So please call your therapist and let them know if you have new orders, there's been a change in your patient, or you need them for anything, even if it's just to come check your patient out. Thank you so much for your time and attention today, and thank you very much for choosing Jackson for your new home.